It can be extensive disease in the breast itself or disease that's gone beyond the breast. So I was thinking about this a great deal, that when we go through life, whether in your 30s, 40s, 50s, 60s, our audience today, many of us just think there are endless possibilities. And I think that's a good thing for women. I think we shouldn't put a cap on where we think we can go with our lives. And then one day, you're told you have advanced breast cancer, and suddenly there seems to be a cap or roof on where you can go. And I like women of all ages, understanding that, we can do all sorts of things. And suddenly you faced your own mortality. Now, I am 69. I was diagnosed with an early breast cancer very recently. But I have to tell you, even at 69, I sort of thought, well, I can still do and go and do whatever I want. And you can imagine that for a 69-year-old woman. What about a woman in her 30s or 40s who's facing advanced breast cancer? So your question about how it impacts us with depression and loneliness and sadness, of course, because suddenly we say to ourselves, well, I'm not going to live forever. I mean, we all know that, but it's more tangible. That's the first thing. The other thing is, if you're a mother, you immediately think about your children. What is the impact on my children? And if you're a daughter and your parents are still alive, you think, I'm not going to be able to help take care of my parents. So I think that's the first thing that women think about. What are the implications? And then you add on to that, will I be able to work? Will I be able to continue my insurance coverage so I can receive the treatment? Because what if I can't go to work? And what is the cost? We all know how many people end up with prohibitive costs and bankruptcy because of healthcare treatment. And getting back to the definition of advanced breast cancer, thinking about having to have extensive body transforming surgery if it's a large breast, and the potential for chemotherapy. And what does that mean for me as a woman? This changing what my body looks like and losing my hair potentially. And of course, then there's death. So I think, yes, there is a higher risk for emotional distress. And that's why every comprehensive breast program should have a social worker and a network of support groups to help women with emotional distress, including depression, the anxiety of all those questions I just said, and the grief of loss of your life as you know it. I liked your question about loneliness, because many women put up a barrier. They want to be strong, or more importantly, they don't want to be, quote, a burden to their children or those around them. And that I encourage people to understand that it's the greatest gift you can give to somebody else, to allow them to help you. And the great thing that's happening, and women are amazing, aren't they? Creating support groups, not just support groups in the context of having breast cancer, but social groups, organizing meals, taking the children to soccer, or if you're older, picking up your dry cleaning. Women are amazing. And so the issue of loneliness, if a woman can allow herself to her friends and family to help her out, she should understand that's a gift to them. Well, we just had a discussion here in our breast center on implicit bias last week. And it really stuck with me about bias, that the most important word is pause. When you are seeing somebody new, whether you're a provider or a patient, to pause. So I was thinking, implicit to a provider, we want to give patients realistic hope. I want to emphasize realistic, but I want to emphasize hope. It is wrong for me to suggest to someone who has metastatic disease they're going to live forever, right? That's wrong. But we know if you take away hope from someone, that it's wrong. But it has to be realistic hope. So there is this bias when we have patients with advanced disease. Some providers might retreat into not wanting to tell them the truth and to frame it. It takes a lot of time. And for all of us who are patients, we know that time is a precious commodity when you see your provider. So I'm not sure this question was about this bias of how we as providers might feel about patients with advanced disease, but I want to throw it in there. There's also cultural, racial, socioeconomic bias. And I think that this session we had here, that when you feel some sort of bias, immediately the first word should be pause. Pause and think about that bias. But it's a two-way street. And I often am worried that when I have a patient who doesn't speak the same language that I do, that she may have bias against me in that she's afraid that I cannot understand her life. So bias goes both ways. And I'm lucky that where I work, I have translators who are trained, and that is helpful. But still, how can you turn your life over to a provider if you think that provider cannot understand your socioeconomic status or your language or your culture, different religious areas? And so I think it's really, really important, that word pause, when we have bias. And perhaps we should encourage patients to also have pause. Give me benefit of the doubt. They do. I'm very lucky, but it is a two-way dance. And we have to be able to get beyond where we come from, or the color of our skin, or our language, in order to get to what the most important thing is: to build trust, have a foundation of a trusting relationship with the patient, so that hopefully bias will not be the centerpiece of that relationship, so we can get into the issues of advanced breast cancer. When I meet a patient, I ask about their family, and I try to relate, may tell them about my son, to relate to their children, our parents, ask them where they're from, if I've traveled there. I always apologize that I can't speak their language, that we have to rely on a translator. Again, I'm lucky I have a great translator who is warm with the patients, but I try to show my humanness. Sometimes I tell them about my cancer so they can understand that that I'm relating to them. So I try to use those elements so that I'm a human to human relating to them, so that they can understand that I'm not a provider up here and they're a patient, that we're on an equal playing field of, my job is to help you. And many times I'll say to them, tell me how I can help you. This is a question that's dear to my heart, because I work in inner city Hartford and take care of a lot of Black women. And the data is very clear. 33% of Black women, African-American women, women from the Caribbean, develop breast cancer under the age of 50. The U.S. Preventive Services Task Force states don't start mammograms until 50. And many of our family physicians in this area embrace that, because they don't know that young Black women develop breast cancer. The American Cancer Society recommends mammograms at 40, maybe 40 every other year. I am really happy to report in the Annals of Surgical Oncology on October 3rd, 2022, there was a landmark paper saying we should start screening young Black women at the age of 25. Now, I'm not saying mammograms necessarily, but screen them for their risk and follow them. But we have these barriers for women of all ethnicities. The American College of Physicians says don't do breast exams when you do a complete physical. Number two, women are discouraged, I'm putting in quotes, from doing self-exam. You're told to know your breast, but not to do self-exam. And so if 33% of Black women develop breast cancer before the age of 50, and they're not having a breast exam, they're not doing self-exam, and they're not getting mammograms, a third of those women are not entitled to early diagnosis. And the result is 50% of Black women are diagnosed at the point where the breast cancer has already left the breast. So thus, now there is an element of biology. Black women tend to have a more aggressive form of breast cancer biologically, but an article came out last October from Cornell Weill Medical Center in New York that says if mammograms are done, that will supersede the aggressiveness of the disease. And I don't think you have to have a paper or research. It's common sense. If you're going to have an aggressive cancer, let's find it early. Let's find it small before it spread beyond the breast. So this is, I could go on for the remainder of this conversation about this, but I won't. But I feel very strongly. I'm very glad you brought this issue up. In healthcare, across the board, we talk about risk stratification. If my mother had a heart attack at 42, I should be screened for heart disease. Women of Jewish Ashkenazic descent have an increased risk of being BRCA positive. Screen them. Young Black women and equally young Latino women or Hispanic women also develop breast cancer young. So all I'm asking, and I'm not alone, there are 14 different institutions around this country that feel the same way about screening at younger ages. All we're asking is look at a woman's risk and let's screen her appropriately. I think that the language issue is huge, and inherent mistrust. If a Latino woman has been mistreated by a healthcare provider in the past, how is she to assume I'm not going to do the same? So we have to break down those barriers. You use the term far better than I. Being human with people, trying to find the common ground. Healthcare access, culturally, if women don't feel comfortable touching their breasts in self-exam, time with your provider. That is such a commodity that's undervalued, and it's so important because I think you can't build trust without time, even with your primary care physician. Healthcare coverage. Women who are coming into the country and not understanding the healthcare system. But let's talk about, there are a lot of Hispanic women in this country right now and been here for years. And how can we make them more comfortable, more willing to trust us? And the same factors we talked on before. But I think what's important, and I love outreach. I love outreach to all different groups. And what has been documented clearly, and I've looked at the research in this, is programs like ours, breast programs, need to have outreach workers that are culturally sensitive. Usually it should be someone in the community that's already trusted from a community group or a church organization, and then equip that woman or man, or regardless of who they are, with the facts so they can be in the community, because they're going to be more credible than me, right? Particularly if they can speak the language. So I think we have to think out of the box. It isn't just in the room with the doctor and the patient, although it is my responsibility to learn how to be more trustworthy. But we also need to think out of the box how we can bring women in from outside the community, and how we do that is with outreach workers who are trusted, speak the language, and understand the culture. And that's really important. And there's data to support that. Well, there are community health centers all around the country that are available. I'll speak to my program here, but I think this can be duplicated, multiple programs in the state of Connecticut and all across the country. October's Breast Cancer Awareness Month. Listen, I cannot believe there aren't multiple institutions in each city, in each town, that provide free mammograms. There are donors that provide these free mammograms. And I think that women need to be proactive in saying, I don't have a doctor. My mother had breast cancer. I haven't seen a doctor. Where can I get a free mammogram? And probably each state has a resource, a number, but they need to be aware, because we sometimes have too much money, that we have so many free mammograms available and we're not utilizing the funds. But a lot of people who are philanthropic, who have been touched by breast cancer, provide funding. And I can't speak to specifics of other places, but I know we do it here. And there's also what's called the CDC program. It's a federal funded program for women to be able to have pap smears as well as breast exams and mammograms. And that is national. Not all hospitals have the CDC program, but it is, I'm sure it's strong in in each community, but it's available across the country. I think that it's important to always hang on to hope and to define what gives value in your life, which is really probably for all of us relationships. It's not things or money, it's relationships. And before we have advanced cancers or early cancers, we need to cultivate our relationships. I like to say life is like a pie chart. There's only so much time for each thing, but I encourage women to take care of their own health, cultivate their relationships, and then if they're diagnosed with advanced breast cancer, to counsel them to turn to their faith to help them through it, turn to their friends and their family. Any of us our life could end today crossing a street. So life is not infinite. Despite what I said at the beginning of this interview, it is finite, and make the most of all that time. And if you have advanced breast cancer, find a provider that you trust. And if the first one you don't trust, find another one that you feel comfortable with, that you don't feel that there's bias, but that key word, trust. Bring your family and friends in with you for the discussions. And then as a community of family and friends with your provider, a whole community, move forward to cherish every day you have with those people that you love. Embrace the therapies. Make sure you believe in those therapies. If not, again, I'm going to be redundant and say get a second opinion, and enjoy each day that you have, because even if you don't have advanced breast cancer, that's what we should do. And too frequently, we take each of those days and relationships for granted.